Hello, Professor Jackowski, and welcome to our presentation, Trapped by Fear, Understanding and Treating Agoraphobia. My name is Reese Bagaja, and I'll be presenting today with Caroline Ouellette, Leonardo Plummer, Hamza Nadeem, and Jay Modi. I'll be defining agoraphobia and outlining its key features. Then Leonardo will discuss cognitive restructuring as a treatment approach, followed by Caroline, who will be covering physical techniques. Jay will then present on relapse prevention strategies. And finally, Hamza will conclude with exposure-based treatment as the best option. Now, onto agoraphobia, background and clinical description. Agoraphobia is defined as a disorder characterized by marked fear or anxiety across multiple types of situations, particularly those occurring outside the home. These situations are feared because the individual anticipates that escape may be difficult or that help may not be available if distressing or panic-like symptoms occur. As a result, these situations consistently provoke anxiety and are often avoided, endured only with intense distress, or managed through the presence of a companion. Importantly, the level of fear experienced is disproportionate to the actual danger posed by the situation and tends to persist over time rather than being limited to a brief or context-specific response. This pattern of fear and avoidance leads to significant impairment in daily functioning, including disruptions in social, occupational, and other important areas of life. The causes of agoraphobia can be understood as developing through cognitive behavioral mechanisms and broader contextual risk factors. From a cognitive behavioral perspective, the disorder is closely linked to panic-related processes, where individuals become highly sensitive to bodily sensations and begin to interpret them as signs of catastrophic outcomes. This pattern involves an overestimation of threat and a tendency to misinterpret physical sensations, such as in breathing or heart rate, as dangerous, while simultaneously underestimating one's ability to cope with these experiences. Over time, this leads to anticipatory fear and increasing avoidance of situations where these sensations might occur, which reinforces the belief that these situations are unsafe and maintains the cycle of anxiety. In addition to these cognitive and behavioral processes, broader contextual factors also contribute to the development of agoraphobia. These include environmental stressors, exposure to traumatic life events, and early experiences such as childhood trauma, which may shape how individuals perceive and respond to threat. Genetic vulnerability and socioeconomic conditions may further influence risk, highlighting that agoraphobia does not emerge from a single cause and never will, but rather from the interaction of individual psychological and environmental factors. The population of those with agoraphobia. Agoraphobia can affect individuals across the lifespan. Although onset most commonly occurs in early adulthood, the majority of cases begin before the age of 35, with an average onset in the early 20s, although it is important to recognize that the disorder can emerge at any age, including later in life. There are also notable sex and gender differences in how the disorder presents, particularly in patterns of comorbidity, with men more likely to experience co-occurring substance use disorders. A footnote: what about all the other genders? They, the DSM, never really ask why there's a binary gender difference, do they? Probably because the answer would affect what they mean by patterns of comorbidity, and maybe because acknowledging gender as a spectrum would require the removal of gender dysphoria in the DSM. End of footnote. More broadly, agoraphobia is rarely experienced in isolation, as the vast majority of individuals also meet criteria for additional conditions, most commonly other anxiety disorders or depression. Finally, understanding agoraphobia requires attention to sociocultural context, as behaviors that may appear avoidant in one context could be normative or adaptive in another. The clinician must interpret symptoms within the individual's cultural and environmental background, rather than applying a purely universal standard. The prevalence of agoraphobia in Canadian society. Canadian statistics specific to agoraphobia come from a 2002 Statistics Canada survey, which reported a 12-month prevalence of 0.7% among Canadians aged 15 and older. That survey also found a notable gender difference, with prevalence estimated at 1.1% among women compared with 0.4% among men. Although these data are now more than 2 decades old, they remain useful because they provide one of the clearest disorder-specific prevalence estimates currently available in the Canadian context. It must be noted, however, that recent Canadian mental health reporting often presents broad indicators or grouped categories rather than disorder-specific estimates. For example, Statistics Canada's Mental Health Indicators 2024 reports categories such as any selected disorder, any mood disorder, and generalized anxiety disorder, but does not isolate agoraphobia as a standalone estimate. As a result, agoraphobia-specific Canadian prevalence data remains limited, and earlier estimates are often relied upon. This goes for Healthcareistics annual estimates in active 2023 as well, which places agoraphobia somewhere under anxiety disorders. The symptoms of agoraphobia. Agoraphobia symptoms can be understood as an interaction between the physiological arousal, threat-based thinking, and avoidance behavior. Physically, individuals often experience symptoms of heightened autonomic activation, such as cardiovascular arousal, dizziness, and respiratory distress, which are consistent with activation of the body's fear response system. These sensations are uncomfortable for the individual and frequently are misinterpreted as signs of impending danger or loss of control. Cognitively, individuals tend to anticipate negative outcomes, particularly in situations where escape may be difficult, leading to persistent anticipatory anxiety and catastrophic interpretations of both external situations and internal bodily sensations. Behaviorally, these experiences are maintained through avoidance and safety behaviors, such as limiting movement, relying on companions, or remaining near perceived exits, which reduce anxiety in the short term but reinforce the belief that these situations are unsafe. Over time, this pattern can become increasingly restrictive, significantly limiting independence and daily functioning. Ways to address agoraphobia. Agoraphobia is typically addressed through cognitive behavioral approaches that target the processes maintaining anxiety rather than focusing solely on symptom reduction. Within this framework, exposure is used to directly interrupt avoidance patterns by creating opportunities for new learning, particularly by disconfirming threat-related predictions and reducing the reliance on safety behaviors. Cognitive interventions complement this by helping individuals evaluate the accuracy of their appraisals and shift their relationship to distressing thoughts, treating them as testable interpretations rather than facts. Behavioral activation further supports change by increasing contact with reinforcing experiences, which can counteract the narrowing of daily life that often develops over time. In addition, physical techniques are used to address the physiological components of anxiety, supporting regulation of arousal so that individuals can remain engaged long enough for cognitive and behavioral learning to occur. The goals for the treatment of agoraphobia focus on targeting the process that maintain anxiety across behavioral, cognitive, and physiological domains. Exposure-based interventions aim to reduce avoidance by creating opportunities for new learning, allowing individuals to directly test their expectations and discover that feared outcomes are less likely or more manageable than anticipated. Exposure-based cognitive behavioral therapy has consistently demonstrated large effect sizes and sustained symptom improvement across a range of anxiety disorders, often outperforming non-exposure-based CBT approaches. Cognitive restructuring works alongside this by helping individuals evaluate the accuracy of their thoughts and develop more balanced interpretations. Cognitive restructuring has been supported as an active mechanism of therapeutic change. As Zawas and Holland's 2023 findings indicate that therapist-delivered cognitive restructuring within sessions is positively associated with improved psychotherapy outcomes. Behavioral activation further supports recovery by increasing engagement in daily activities, which can counteract withdrawal and improve overall functioning. Evidence from Gia et al.'s 2025 meta-analysis indicates that behavioral activation, especially when virtually delivered, is effective in reducing depression and anxiety symptoms and enhancing functioning. Finally, physical techniques address the physiological aspects of anxiety, helping individuals regulate arousal and tolerate feared situations more effectively. The efficacy of physical techniques, particularly breathing exercise, is evidenced by Malik et al.'s study. Their study indicates that breathing exercises can significantly reduce anxiety symptoms by improving physiological regulation, particularly through the reduction of dysfunctional respiratory patterns. Overall, agoraphobia can be understood as a disorder maintained by the interaction of cognitive, behavioral, and physiological processes, rather than as a response to specific situations alone. As we have seen, individuals are not simply afraid of environments, but of what they believe might happen within them, particularly when bodily sensations are misinterpreted as dangerous and coping ability is underestimated. This understanding asserts why CBT approaches are effective, as they directly target the maintenance processes of agoraphobia through exposure, cognitive change, behavioral activation, and physiological regulation. Altogether, each of these interventions reduce can aim to reduce symptoms, restore functioning, and increase the individual's ability to engage more fully with their daily lives. Now, with that foundation in place, I will now pass it over to Leonardo, who will continue by discussing cognitive restructuring as a treatment option.
Cognitive restructuring may work as a central therapeutic component in the treatment of agoraphobia. I will look at the five core principles of cognitive restructuring and its effectiveness in treating agoraphobia. This section will highlight a clinical case where the use of cognitive restructuring in therapy has helped to restore functional independence in a 38-year-old with moderate agoraphobia. Cognitive restructuring is a core cognitive behavioral therapy technique that involves identifying, examining, and modifying dysfunctional or maladaptive thought patterns. Cognitive restructuring targets cognitive biases by guiding clients to critically evaluate their thoughts and develop more balanced interpretations. Have you ever wondered why certain thoughts make you feel anxious? And what if changing those thoughts could change how you feel? Cognitive restructuring has five core principles, and we believe that these principles can be applied to the treatment of agoraphobia when followed in a structured and systematic way. The process begins with helping patients identify automatic thoughts that arise in anticipation of or during agoraphobic situations. For example, a patient might notice the thought, I am trapped in this crowded mall and something terrible will happen. This now leads us to our next step, which is spot thinking errors. This is when the therapist will help the client to recognize the unhelpful thinking patterns, like catastrophizing or overestimating the risk. The therapist will then employ Socratic questioning techniques to help the patient examine evidence supporting and refuting these thoughts. The client may hear questions such as, how many times have you been in crowded malls? How many times did something terrible actually occur? Through this guided examination, patients may develop more realistic alternative thoughts, which is essentially the goal of cognitive restructuring. Patients will now start saying, I feel anxious in crowded spaces, but I am not trapped. I can leave if needed, and nothing catastrophic has happened in the past. Importantly, these cognitive changes are not imposed, but collaboratively developed and then tested through behavioral experiments. The patient actually enters the feared situation, and I think this is very essential. I believe that it is needed. And what they would do in this regard is to observe whether the predicted catastrophe will occur. This integration of cognitive restructuring with behavioral exposure creates a powerful learning mechanism that changes both cognitive beliefs and behavioral patterns. Let's look at how cognitive restructuring works in real life using the clinical case of Sarah, who is 38 years old with 18 months of avoidance history. She fears crowded malls and public transportation. We'll be looking at her presentation, her cognitive identification, thinking errors, Socratic disputation, rational response, and the outcome. So she struggles with agoraphobia, especially fears about panicking and losing control in the mall. Her automatic thoughts often sound like, if I go into a crowded place, I lose control and everyone will notice. In therapy, we first help Sarah recognize these thoughts. Our example of catastrophizing, which simply means that she is expecting the worst out of her situation and her overestimating how likely it is to happen. Next, we use gentle questioning to look at the facts from her own life. Has she ever actually lost control? Has she fainted before or been humiliated in a mall? Sarah will realize that even when she's very anxious, the worst never actually happened. With this evidence, Sarah learns to create a more balanced thought. She'll start saying, I get anxious in the malls. But anxiety isn't dangerous. I have never truly lost control before, and it's unlikely to happen now. As therapists, we don't stop there. Sarah takes this new thought and puts it to the test by going into a mall. And instead of expecting the worst, she enters with her new realistic prediction. She notices her anxiety, but it doesn't spiral out of control. No one points out her anxiety, and she's able to leave on her own terms. This process shows how combining cognitive restructuring with real life practice can help people with agoraphobia change both their thoughts and their behavior. And I want to stress on the outcome. Sarah goes to the mall for 30 minutes, and here we find that her anxiety will decrease, there's no catastrophe, and her self efficacy increased. This is how cognitive restructuring works in restoring someone's functional independence. Let us now look at the effectiveness of cognitive restructuring. Research strongly supports the use of cognitive restructuring in treating agoraphobia, especially when it is combined with exposure based behavioral strategies. A major study compared two internet based treatments for people with panic disorder and agoraphobia. One group received just exposure therapy, and the other had a more complete CBT program that included cognitive restructuring, breathing techniques, and exposure. Significantly, both groups showed large improvements in their agoraphobia symptoms with no significant difference in how well they did, how many people finished treatment, or how satisfied they were. This tells us that exposure alone is very effective, or it can be more effective, even without formal cognitive restructuring. It is found that many people get better. Research, however, has shown that cognitive changes, like learning to think differently about anxiety, are strongly linked to symptom improvement. In particular, building self efficacy, or a person's belief in their ability to handle anxious situations, seems to be a key factor in recovery. Cognitive restructuring is especially helpful in this regard. So, while not every person absolutely needs cognitive restructuring to improve, it can make a big difference, especially for those who struggle with catastrophic thinking or have high anxiety about facing feared situations. In these cases, cognitive restructuring is found to speed up progress and help people feel more confident and in control of their thought patterns. It must be highlighted that cognitive restructuring is insufficient as a standalone intervention, therefore, highlighting its limitations. Cognitive restructuring requires active behavioral components to produce optimal outcomes. Without exposure and corrective behavioral experiences, cognitive restructuring will fail to generate lasting symptom reduction. Thought change must be paired with behavioral practice for treatment efficacy. There's also a cognitive emotional disconnect and misapplication. Cognitive change does not automatically translate to emotional change, which means patients may intellectually understand that their agoraphobic predictions are unlikely, yet continue to experience intense anxiety. There is also limited applicability across populations. Cognitive restructuring requires adequate cognitive capacity, psychological mindedness, and introspective ability. This is significantly limited in its applicability for individuals with intellectual disabilities, severe depression, low insight, or neurodevelopmental differences, who may struggle with abstract thinking. It also has limitations in culture. So we find that it is embedded in individualistic Western psychological assumptions that may not align with collectivist cultures or diverse spiritual and belief systems. Successful cross cultural implementation requires substantial cultural adaptation, making this approach less universally applicable without significant modification. I now introduce you to my next teammate that will be looking at the physical techniques and how they can help in the treatment of agoraphobia.
Physical techniques are a form of therapy to restore the body's physiological state to a resting state, and in turn changes the cognitive interpretation or deconditioning the response to a trigger, resulting in a change in the behavior. When the client is experiencing an episode of agoraphobia, they undergo fight or flight response and experience symptoms such as increased heart rate, rapid breathing, lightheadedness, upset stomach, cool and clammy skin, and muscular tension. This is a result of decreased vagal control and prefrontal inhibition of subcortical defensive activation. The individual has conditioned the thoughts and experience of agoraphobia with these sympathetic nervous symptoms, so the goal is to reduce those symptoms. The parasympathetic response to bring the body back to a resting state. It is also providing the client an alternative response to the perceived threat or trigger. When the emotion is managed with physical intervention, it changes the response pattern. Relaxation techniques. Dr. Edmund Jacobson demonstrated that the mind and muscle work together. If the mind is not calm, the body will be tense. So if the body can relax, the mind will calm. Relaxation techniques include following an audio relaxation script, relaxing various parts of the body. This is called progressive relaxation, deep relaxation, shortened progressive relaxation, and simple relaxation. And apply tension, whereby the muscles are tensed up and relaxed. The key is to relax the body, return it to a resting state, and in turn, de-stress the mind. As you can see in this diagram from Benucci et al., people suffering from agoraphobia exhibit a maladaptive response. This response exhibits dysfunctional breathing. To correct this, the individual can use some breathing techniques. One well-known breathing technique is the box breathing. The individual inhales through the nose for 4 seconds, holds the breath for 4 seconds, slowly exhales for 4 seconds, and holds for another 4 seconds. The individual does this until they feel calm. Another breathing technique is the 4-7-8. The person inhales through the nose for 4 seconds, holds the breath for 7 seconds, and slowly exhales for 8 seconds. Another popular method is using yoga breathing, also known as pranayama. It stimulates the vagus nerve and parasympathetic nervous system response. This calms the emotional centers of the brain, particularly the amygdala, prefrontal cortex, and insula, which are involved in anxiety regulation. Physical exercise. Physical exercise can include, but not limited to, walking, running, riding a bike, swimming, team sport, dancing, and aerobic exercise. Physical exercise increases blood flow to the brain, which stimulates the release of naturally occurring mood enhancing chemicals, which are similar to morphine and have been linked to the runner's high. As well, the type, amount, and intensity of exercise can positively affect a person's mental health. In a study by Mutri et al. 2026, participants' panic attack frequency and intensity decreased within 12 weeks of physical exercise. Intermittent frequency and high intensity of physical exercise, such as aerobics, are required to have the desired outcome. It is recommended to combine physical exercises with another type of therapy, such as exposure therapy. Sleep management. Why does the person need sleep? The first hypothesis is to restore and repair. The body needs to restore energy to its full capacity for functioning and to repair any damage sustained during the day's activities. When a person sleeps, the waste removal pathway dilates, making waste removal more efficient. When the body is restored to optimal functioning, it improves the ability to learn new tasks. The second hypothesis is to preserve and protect the person. The body needs sleep to preserve energy and protect the person from harm. Sleep deprivation prevents the body from preserving and protecting itself, resulting in neuronal degeneration. Sleep deprivation also prevents the body from dreaming. Dreams serve the purpose of activating brain activity required to help interpret the body's sensory experiences for that day. Dreams also serve the purpose of learning from memory of daily sensory experiences. Sleep disorder, such as insomnia, somnambulism, sleep apnea, and narcolepsy, can affect a person's mood and cognitive and behavioral functions. Poor sleep perpetuates repetitive negative thinking about a perceived threat. The good and the bad. The good? Relaxation. It decreases stress and breaks the response to the physical symptoms, removing the conditioning of agoraphobia with positive physical symptoms. Breathing, short-term coping, and distraction strategy. Exercise promotes neuroplasticity and synaptogenesis, which helps the brain to adapt to stressors and structural changes in areas of the brain that regulates emotions and stress response. Lastly, quality sleep improves cognitive alertness, behavioral responses, and elevates mood. The bad? Relaxation is a safety-seeking behavior. Inability to relax at a high arousal state can be experienced as a loss of control and hypersensitivity to small bodily changes. Breathing, another safety-seeking behavior. Difficulty with using breathing when in a state of panic, contraindicated to some physical disorders, and hypersensitivity to small bodily changes. Exercise. Exercise can become overvalued, contraindicated to some physical disorder, hypersensitivity to small bodily changes, and difficulty with physical activities. Lastly, sleep may be secondary to other health problems, beliefs in bed or by day, safety-seeking behavior, poor stimulus and temporal control of sleep, and distorted perception of sleep. Physical techniques should be used in combination with cognitive and behavioral techniques. Different physical techniques can be used as a form of symptom management and distraction when experiencing symptoms of agoraphobia. There are no adverse effects from using physical techniques unless they are contraindicated for certain medical conditions.
Relapse prevention therapy. Although CBT is highly effective in reducing anxiety symptoms, sustaining these improvements over time remains a critical aspect of treatment. I will talk and follow through on why relapse prevention therapy is essential. Relapse prevention. What is relapse prevention in CBT? Relapse prevention is an essential part of CBT, particularly for anxiety disorders such as agoraphobia. It focuses on maintaining clients and helping them through the process that they have made during therapy and reduce the likelihood of symptoms returning. Rather than viewing relapse as failure, CBT frames it as a normal part of the recovery process. Clients are taught to recognize early warnings, signs of anxiety, such as increased avoidance or negative thinking patterns, and respond using coping strategies learned in therapy. The goal is to build long term independence and ensure that clients can manage anxiety effectively even after treatment has ended. Relapse prevention strategies. In CBT, relapse prevention involves several key strategies. One of the most important is continuing exposure practice even after symptoms improve to prevent avoidance from returning. Clients are also encouraged to identify personal triggers that may increase anxiety, such as stress or life changes. Cognitive restructuring remains important as clients must continue challenging negative thoughts such as, I can't handle this. Additionally, coping strategies such as breathing exercises and grounding techniques can help manage anxiety in the moment. Finally, therapists often work with clients to develop a relapse prevention plan, which outlines what steps exactly to take if symptoms begin to return. Why is relapse prevention so important? Relapse prevention is especially important because anxiety disorders like agoraphobia can be chronic if not properly managed. Without continued practice, individuals may gradually return to avoidance behaviors, which can quickly reestablish the anxiety cycle. By equipping clients with tools and strategies, CBT helps build confidence in their ability to cope with anxiety independently. This promotes long term recovery and reduces reliance on therapy. Ultimately, relapse prevention ensures that skills learned during treatment are sustained over time, allowing clients to maintain progress and improve their overall quality of life.
Hello, everyone. For this next portion of our presentation, I will be shifting our focus to exposure therapy as a treatment for agoraphobia. As mentioned before, agoraphobia is uniquely debilitating, and it's defined by its terrifying and progressive shrinking of a client's world due to the perceived inability to escape. Therefore, as outlined by Kennerly and colleagues 2017, the ultimate goal of exposure therapy is not only symptom reduction or simply surviving a panic episode. The true clinical goal relies within the ability to reclaim functional mobility and returning the client's life space. Over the next few minutes, I will have the floor to trace the historical roots of exposure in early behaviorism, examining the evolution through waves of CBT and confront its clinical limitations. Finally, we will review the current literature to demonstrate why a blended exposure model remains the gold standard treatment for clients with agoraphobia. Now that we understand the clinical goal of exposure therapy, let's see how the core principles of exposure therapy actually work. Exposure is a direct and systemic confrontation of feared situations, grounded in the seminal principle of extinction outlined by Porter and colleagues in 2006. More recently, Benito and Walther in 2015 have refined the steps into the clinical process called habituation. They claim that exposure only succeeds when three specific conditions are met: intense fear activation, the strict minimization of anxiety reducing behaviors, and natural habituation. To safely achieve this, the therapist and client must collaboratively build a hierarchy, which is a graded list of anxiety provoking situations. The most critical principle across these steps is response prevention, which ties back into the previous section. As Benito and Walther emphasize, if clients use subtle safety behaviors, their anxiety decreases due to negative reinforcement, not habituation, which would sabotage treatment. So, why is exposure therapy an appropriate treatment for agoraphobia? Well, agoraphobia is inherently an avoidance disorder, and exposure directly targets that maintaining mechanism. Taking a look at the clinical application, consider a client whose agoraphobia manifests as a severe liability to take public transport. According to the habituation model outlined by Benito and Walther in 2015, the therapist doesn't prescribe a generic list of bus rides. Instead, they conduct a tailored and functional analysis to determine the client's idiosyncratic core fears. Example being, is the client afraid of trapped or is the client afraid of having a heart attack in public? The fear hierarchy is built around a specific fear. According to Heleke's 2025 data, 47.4% of agoraphobic patients actively overpredict the level of fear they will experience. Benito and Walther note that the exposure to be successful and appropriate, three conditions must be met. The core fear must be triggered actively, all anxiety reducing behaviors must be blocked, and the anxiety must naturally habituate. While exposure is certainly an appropriate model for treating agoraphobia, we must critically examine both its effectiveness and clinical limitations. On the effectiveness, the numbers are undeniable. Historically, as Porter notes, pure exposure yields a 60 to 70% success rate for agoraphobia. More recently, Haleki and colleagues' 2025 trial of 268 patients demonstrated massive clinical improvements. Patients' panic and agoraphobia scale, abbreviated PAS, dropped from a severe baseline average of 27.7 to just 10.5 at follow up. That is nearly a 62% reduction in symptom severity. However, this effectiveness comes with a clinical cost. By definition, there is inherent psychological distress. Consequently, the primary limitation is the high dropout rate. If anxiety is paced too intensely, the client simply leaves. Furthermore, as Kennerly et al. 2017 highlights, clients often deploy covert safety behaviors like mentally distracting themselves. While these behaviors can keep the client in the room, they do undermine the habituation process. Therefore, the ethical reality of exposure requires rigorous informed consent, collaborative pacing, and monitoring. To mitigate the high dropout rates and intense distress that we just discussed, peer exposure is rarely used in isolation today. Instead, we use highly collaborative models. Therapeutically, we integrate motivational interviewing to resolve a client's ambivalence and build their intrinsic readiness to face their panic. We also pull from third wave models like mindfulness. Kennerly et al. In 2017 notes teaching clients to non judgmentally observe their psychological arousal prevents them from relying on safety behaviors. Beyond therapeutic models, we also rely heavily on technological collaboration. Arnfred and colleagues in 2025 highlight we are increasingly blending traditional in vivo exposure with internet based interventions and virtual reality. By collaborating with digital modalities, we can safely simulate highly distressing environments right in the clinic. These therapeutic collaborations work together to keep the client engaged so exposure can truly take effect. Now, taking everything into account, because of these highly effective therapeutic and technological collaborations, we conclude that the best treatment for agoraphobia is exposure therapy. While cognitive restructuring, relaxation, and relapse prevention are helpful additives, the literature agrees that behavioral exposure is the undisputed active ingredient for recovery. However, the best modern iteration of this model is blended. A 2025 randomized controlled trial by Plannert and colleagues tested this by blending standard CBT with mobile virtual reality and internet modules. The statistics strongly support this model. Patients using the blended VR approach achieved a 37.5% clinician rated remission rate at their 6-week follow up. This was statistically significant superiority over the active control group, proving that integrating these collaborative technologies combines the unparalleled efficacy of traditional exposure with the accessibility severely avoidant clients need, making this the best practice today. To conclude this presentation, I want to leave you with a few key takeaways for future practice. Firstly, if you're treating agoraphobia, you must prioritize exposure. It is the evidence based gold standard. Secondly, maximize that exposure by conducting a tailored functional analysis, actively tracking your client's expected fear, and ethically fading their safety behaviors. Third, do not practice in a silo. Embrace collaborative therapeutic models mentioned in this presentation, as all the mentioned treatments have unique benefits that may work for the nuance needed in practice. Inherently, we are a field that thrives off nuance, and our approaches must be tailored towards that. Ultimately, our goal is not just to reduce panic, but help clients reclaim life space. Thank you so much for your guys' time.